Just 1 minute. Okay, here we go. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning from Miami Beach. This is Dr. John Bennett, home of Neurosurgical TV. Today we're starting a series of from Tanzania on grand rounds for skull-based surgery and neurovascular rounds. So I'd like to start the proceedings by calling on Juma Magogo. He's a neurosurgeon. We've done a lot of webcasting over the years. He went to India for a while, and now he's back in Tanzania. And then I'll let him carry on. Good day, Juma. Can you hear
Good
me?
day to you and all. Can you hear me?
Yes, go ahead. Go ahead.
It's a great pleasure to be in this forum. It's a new forum that we and Dr. Ipe, together with Dr. John Bennett, together have come to an opinion that we should have a Tanzanian grand round. We should present our cases and learn from the great renowned surgeons, the like of Professor Ipe. Actually, this thing is endorsed by our association here, the Tanzania Neurosurgical Association, and the Muhimbili Orthopedic Institute, which is the most referral hospital here in Dar es Salaam, Tanzania. They're actually not here today because we are just starting. We thought maybe because of the Zoom testing, maybe the next session they will be here. Yeah, just be assured that we are blessed with we have their blessing to start this session. The formality of presentation will be Zoom as hosted by Dr. John Bennett, who has been very instrumental and very helpful to the low limited resources countries, like in Tanzania, where we, through Neurosurgical TV, we get a lot of education materials. Just to introduce myself and the team, I'm Dr. Juma Magogo. I'm still an attending neurosurgeon. I'm learning to become as good hands as Professor Ipe. And the rest of the team will introduce themselves. And then we'll be presenting one case from Dr. Max here. That will be a good start. And then we'll also like to hear opinion of this case from Professor Ipe, as well as listening to a lecture that will be given by Professor Ipe or from Ram Kumar and Takashi as well. So welcome everyone in this new forum, and we hope we will make it successful. One of the most resourceful forum in the continent. In the future, we will invite some colleagues from our nearby countries, the College of Surgeons in East and Central Africa. So we hope that with time, we'll get a lot of attention from around East Africa. Thank you for this introduction. So I give this mic to Dr. Max.
Thank you. My name is Dr. Max Gamondosi. I am junior attending neurosurgeon. Just finished my my studies last 2 years. Now it's my pleasure to be here with Professor Ipe and others. I'm glad I'll learn a lot because he's my mentor. We did some cases when he came to Tanzania, and then after he went back, we did many cases until now, 6 cases from his experience.
Yes, good afternoon, everyone. My name is Dr. Lawrence Chisitu. I'm a junior resident at Muhimbili Neurosurgical Institute under the College of Surgeons of East Central and Southern Africa. Thank you for the opportunity to learn with us.
Yes, hello everyone. I'm Boaz Yona, senior resident in neurosurgery department on my last year of training. It has been a pleasure attending these sessions, and we're expecting to learn a lot from you. Thank you so much.
Hello, everyone. My name is Dr. Susan Stoller. I'm a general practitioner at Muhimbili Orthopedic Institute, and I am glad that I have the pleasure to join this meeting. Thank you.
So that's it. That's our team, and other people will join online from the participants you can see. But we'll be using this classroom for our normal presentation. It's well equipped with the internet and the PA system for presentation. Without further ado, maybe I should welcome Dr. Max Gamandosi to present. Or maybe we can hear introduction from the participants. From Takashi and Yandongsu. We'll be happy if you introduce yourself as well.
He may have stepped away, Dr. Juma.
I mean, can you introduce the team?
Sure, I
we don't
can
know
introduce Takashi Khan. He's a neurosurgeon that really likes using this platform from Japan. He does a lot of translating into Japan to the Japanese neurosurgical community. Welcome, Takashi.
Hey, good evening. Good evening. So nice to meet you, Tanzania. I've never been to Tanzania, so I'm very interested in the Sub-Saharan Neurosurgical Society. I'm very interested, so I'm eager, exciting to understand your neurosurgery. Thank you.
Yeah, I guess Rukuma, could you briefly introduce yourself, please? Hello, maybe not. Are you there, Rukuma? You want to introduce yourself? No? Okay. Okay, Dr. Jumar, so go ahead. Can you introduce Ike, please?
Oh, so I'm humbled to introduce Professor Ipe. Professor Ipe is the neurosurgeon at Krishna Hospital in Mumbai, in India. He's the member of the WFNS and one of the most renowned skull-based neurosurgeon. He's the inventor of the cystenostomy that has been published, over 10 articles that have been published. And he's an expert on using the current exoscope machine that is the future of the neurosurgical visualization. So we are very humbled to hear presentation and more from him. Welcome, Professor Ipe. So without further ado, maybe we should share our case and then we can ask Dr. Max to present and then start right away the presentation.
Okay. Ipe,
Yeah,
okay, go ahead.
I'm looking forward to see the case, and I'm very proud of these guys. I mean, when I went to Tanzania, what I found was their ability to do things was fantastic. It's just that they had to be told you can do it, and that's all they needed. Everything else was good.
You want to put it on presentation mode, Ipe? Ipe, can you put it on presentation mode?
Hello, John. It's
Yeah,
them.
can you? Yeah, I
them.
can see it. Can you put it on presentation mode? please?
Juma is doing it.
Oh, okay. Do you know how to put on presentation mode, Juma? At the very
Yes.
bottom of the screen, there's an option. The bottom right, there's an option next to comments at the bottom. At the bottom, you see the bottom? There you
See
go,
the
there you go, there you go. One of those options, right. Go ahead, try each one of those options. Down there, you're in the right spot. Go ahead, try the option. One of those options down at the bottom, at the bottom. Oh,
So
seamless, perfect. Perfect.
Okay. So may I take you through the case? So that pictures is from Dar es Salaam during sunset, and on the right hand side that is Moi, our new building where we have 600 beds. Oh. So the case may I present to you 36 years old. Can you see the presentation?
We see the first page, Dar during sunset.
Okay.
Case
So,
one, okay, we got it.
Yes, that is 36 years old male who present with left side weakness for 1 month. The weakness was gradual onset on the left side, both upper and lower limbs, associated with the loss of balance, some headaches and blurred vision on the ipsilateral side, with ringing of sound in the ears, which after a week it gets subsided. No association of conversions, no loss of consciousness or vomiting, no history of trauma prior to presentation. This man, he was working at his IT by professional, and so he doesn't move a lot, and these symptoms are very I mean, they give him like frustration. So on examination, the patient is a lighter febrile, everything is normal. The glaucoma score is 15, pupils are normal and in reaction to light. The upper limb and lower limbs on the left side have grade 4 of power. He can walk by himself, but he's dragging the foot. And then on the left upper limb, he can hold something which is light, but if something is has weight, he will drop it. And the rhombic sign was positive. The cardiovascular respiratory system and per abdomen is essentially normal. So our differential diagnosis was cavernoma versus hemangioblastoma. That is, this is the video which shows the lesion at the brainstem, which is more on the right side. I think everybody can see the image.
Yeah, we can see it.
We record the video by using our phone. But in the later days, we can record them by snipping tool, so as we can see without the glare of the screen. But that is the imaging we have here. The patient also did CTA, which came negative. To rule out the basilar aneurysm or aneurysm around the brainstem. So our discussion is how we'll go about this case. Some of us will say that the patient, from the cavernoma point of view, the symptoms, if the symptoms subsided, but we watchful and wait, and others say we can operate and remove the lesion together with that hematoma, which you see in the MRI on the T2 and on the FLAIR image. So welcome for the discussion.
Should we stop sharing or?
No, you can keep the screen. You can keep the screen on, I guess.
Okay. Professor Ipe, would you like to lead the presentation, please?
Yes, I would very much love to go in a very small subtemporal route and 2 centimeter craniotomy, and I would go under the temporal lobe, and I would take out this lesion. I mean, I will try and enter the lesion where it is coming to the surface. I will try to avoid the motor tracks. So if you can, yes, stop it there, stop. Yeah, stop it there. No, come, can you come down, please? Come down. Yeah, axials, please. We are not seeing it now.
Okay. He's working on
it. Can you see it, sir?
Yeah, can you put a presentation mode at the bottom? Yeah. One of those icons, I'm not sure which one it is. Try another icon at the bottom.
Can you see now?
At the bottom, you gotta, I'm sorry to be repetitious. At the bottom, there's an icon you need to click.
Okay.
The bottom of the screen, below the scan. At the very bottom. There, perfect, perfect. Hey, it's
Yeah.
good. It's good.
Yes, stop it there, please. Stop it there. Yeah, so I would go subtemporal and just behind the maybe I can see there is a hematoma and there is a fluid level there. And I would go to a little bit posterior to where my motor tracks are. So behind probably the substantia nigra. I know the red nucleus is going to be there, but it's I'm sure it would be damaged already. So I would go behind. I mean, the third nerve is going to be coming out through that region. The third nerve fascicles are going to be in that region. So I would avoid the motor tracks and I would go posterior to that, and I'd take out this hematoma plus the entire lesion. It would be eminently possible. This is what I think.
Dr. Ipe, do you think we are dealing with the vascular lesion, or maybe it's a tumor, or I don't know?
Well, I thought this is a cavernoma. There is definitely a fluid level there, And we would like to see the T2 weighted flare series to confirm that it looks more like a cavernoma to me. So this is why, assuming it's a cavernoma, is when I said that I would go take it out. Do you have the contrast and the T1 weighted plus the contrast to see whether there's any difference?
Yes, we discussed this case with the radiologist, and then on the flare, they confirmed that is a carcinoma.
Yeah, so if it's a carcinoma, definitely a small 2 centimeter subtemporal approach, and you probably will need to cut the tent a little bit, and that'll make space, and the medially just a little bit of cutting the tent, and then even there is no need for any Kawase or anything. Just a subtemporal, clean subtemporal approach would be more than enough for this one.
Okay. So do you think in our setting we can do it?
Yes, obviously, yes. 100% yes.
Okay.
You just need to put the head down. See, listen, you are going to put the head. You see the head, and then the head is going to be down like that. I mean, like this. Okay. The head has to be down like that. Then this is the subtemporal craniotomy, small subtemporal craniotomy, like that. And then you very gently, you go, and keep on removing CSF, keep on removing CSF, keep on removing CSF. And then you reach, I mean, you see the tent, and then you reach the cistern, and then you will see the fourth nerve, and you will see the midbrain pons junction. You will see the posterior cerebral artery, and below the tent, you will see the superior cerebral artery. And then you will see the discoloration of this lesion, and then you can put in your bipolar through that, and then evacuate the hematoma and take out using a small tumor holding forceps. You can hold a cavernoma and gently dissect it out with water, and with a very small dissector, you can very gently dissect it out, and then it's out. This is what you need to do.
Sorry, can you repeat how the head will be on that model? Because we couldn't see the illustration on your model, on your.
You need to put the patient in complete lateral position, and then put the head a little bit down. It doesn't matter how down, how much down. Don't worry about the angles or anything. Just a little bit down. That's enough.
So I can see you are holding you are holding the model in the. Yes.
Yeah. So can you see me now? Can you see the model?
Yes.
Can you see the model now? Yes. Maxi, can you see the model?
Yes, yes. We are seeing it. We are seeing it.
Now this is how the model will stay, and I need to just put this model down so that the temporal lobe can easily be retracted. I mean, see, the temporal lobe can easily be retracted away from.
Yeah.
As soon as the temporal lobe is retracted, you know, intradurally, you will have the tent here. The tent would be here, and here would be the midbrain and the pons junction. Above the tent would be the midbrain. So you could cut the tent a little bit. I mean, above the tent would be the superior cerebral, the posterior cerebral arteries. Below the tent, the fourth nerve and the superior cerebral artery. The fourth nerve would be on the margin of the tent. If you find out where the fourth nerve enters the tent, you can cut the tent a little bit. The medial part of the tent, a little bit of the medial part of the tent, you could cut behind where the fourth nerve enters. And you have beautiful, you will have beautiful approach to this tumor. So the tent is going to come up, You see on this image, second image, the tent is going to come up on top of this tube, on top of this cavernoma. So you cut the tent a little bit, medial part of the tent, you will be entering into the pons. The lesion is primarily in the pons. So you would want to enter into the pons. And you would see the discoloration, and then you can direct downwards a bit, and then you get the lesion. That should not be any problem.
Okay, thank you, Professor.
Does anyone have a question from the floor? We are happy if you also present, if you have a similar case like this from your collection, we'll be happy to stop sharing and check out your presentation.
You want to see a subtemporal approach?
Sure, exactly.
Okay, I'll show you that. First of all, I would, can you share my screen? I'm sharing my screen, and we have a cadaver dissection done, and I'll show you the. This is a cadaver dissection we did with my fellows in my Krishna Institute. So that's a Kawase. This is extradural approach to the middle fossa. So we don't need an extradural. This is what I want is an intradural approach. So here Kawase drilling is there. You don't need any of this. But this is intradural. This is the 7th cranial nerve. That's the 5th cranial nerve. So without cutting all that, without cutting the tent or anything, intradurally, where you will reach, if you go subtemporal, where you will reach is the midbrain pons junction. Okay, you will reach way anterior to this, somewhere here you will reach the interpedunclar fossa. You will be able to see the interpedunclar fossa. You will be able to see the third nerve. You'll be able to see the P1. You'll be able to see the superior cerebellar here. Okay, so I'll show you that. Intradurally, you will be able to, extradurally, it's a different story, but intradurally, where you are reaching is exactly here in this region. This is where you will, if you go underneath the once you open the dura, pull up the temporal lobe, you are going to reach from this region to this region. That's a third nerve, fourth nerve, and that's a midbrain pons junction. And this is exactly where your lesion is. Okay. So beneath the P1, in correspondence with the superior cerebellar and fourth nerve. So a little bit of tent needs to be cut here. You will see the fourth nerve entering the tent, and behind that you can cut the tent and take a stitch and then take the tent forward, and then you will get a beautiful exposure of this region. Okay, and then you'll be able to go there. Shouldn't be any problem. Can you guys hear me?
Yes.
Where's Juma?
Hold on, let me check on them iPod. Okay, I don't know if they fell off. They may have fallen off.
Yeah, looks like they.
Yeah, they'll be back. Yeah. They had a stable connection before. I'm sure they'll be back. Just patiently wait. Yeah, as soon as they come back, we'll just continue on. I have confidence they'll be back. They've put a lot of effort into this. So I'm sure the whole team's
We're waiting.
got to get ready. So you've been to Tanzania.
Tell me, John.
Yeah, you've been to Tanzania before, right?
Yes, yes. Just last month I've been to Tanzania. So
Oh, just last month.
maybe in November. November. I
Oh,
was.
okay. Okay. And what city was it in?
Well, I was in the capital and Dar es Salaam, and then I went to Muhimbili Hospital. I operated on a tuberculum meningioma.
Oh, you went to Juma's Hospital where we're
Yes,
broadcasting
I operated
from.
with this team, the same team who is presenting. I operated with them.
Oh, okay. Now I think that's relatively new hospital. It looks.
Muhimbili is not a new hospital, but it's pretty well equipped, very well equipped.
They're pretty well stocked with equipment.
They have a reasonably good microscope. They have equipment, so that's why when they were asking me whether is it possible for them to do this case, I'm sure they would be able to do this case. No question about it.
I hope it's not an electrical shortage. Sometimes these things do happen. Not much you can do about that.
They've come back.
Okay, good, good. Okay, very good. Okay, are you there, Shuma? Can you hear me okay?
We can hear you okay now.
Okay, good. Okay, where did we leave off, gentlemen?
So I was presenting, so we are happy to see Professor Aib's presentation.
Okay, I guess we're gonna put it up again, right?
No, Juma, what I was trying to tell you is that you are going to reach the interpreting, if you go below the temporal lobe, if you retract the temporal lobe slowly in a subtemporal approach, You'll be reaching from the interpedunculair fossa. That's where you open the arachnoid. You will reach the third nerve. You will reach the superior cerebellar. You will reach the PCA, and you will also see the fourth nerve. The fourth nerve you will see in the tent, I mean the medial margin of the tent. And at one point, the fourth nerve will be entering the tent. If you take a stitch and make a small cut behind where the fourth nerve enters the tent, then you'll be able to easily get access to this cavernoma. So you needed a small craniotomy, and then if you get into that pons region, once you will see the discoloration, and then once you put in your bipolar and open up that region, you will get the cavernoma. Shouldn't be any problem. I wish I could come there and be with you for this case, but I'm confident that you guys will be able to do it.
Yes, we will try. We'll try, Professor. Is there other view from the other technique from the floor?
I believe, let's see here, Takashi, no, Takashi left. Okay, any more comments for the panel? Questions? Okay, do you want to move to the next case type? What do you want to do, Dr. Borgo?
We only have one case today for presentation. Today is just a starting. Today is just a starting presentation. We'll be happy to collect some comments, more comments on how to improve this. And then we'll be sending some, we think in the future, we'll be sending cases in advance. We'll be sending to Professor Ipe and to you, Professor Bennett, so that you have them in your computers. When we lost internet here, you can just, when we lose some connection, we can just post it and discuss it.
Okay.
So those are the things that I wanted to share with you.
Okay.
Because it's just a start, and I think to make it formal, we will have the faculty also from our side, our senior guys, probably joining by Zoom if they have time, or they can even come physically here in the classroom. We'll be happy to hear more comments from you, Dr. Bennett, and from the team that is participating today to make this CME very, very useful. We would also think maybe in the future we'll put it in the CPD points. We'll put it as CPD points from the Medical Council of Tanzania, so that we update our knowledge always.
You know, Dr. Magogo, this is a work in progress. We are using the Zoom platform, trying to use it to its maximum efficiency by coming to Tanzania and bringing it together with IPE. So we're just learning, we're just starting, and it's good. The first thing to do for learning, of course, is communication. So we're establishing communication, and we want to maintain that at least every 2 weeks in the format that you and I discuss, whatever you guys decide, case presentation, what didactic lecture, whatever. And we certainly welcome the rest of the African community to join. The world community, actually, it's world, it's not just Africa. You have any comments, Ipe? Are you muted, Ipe? You're muted, Ipe. Okay.
No, I would rather ask Ram Kumar to show his two, the exoscope and the endoscope holder that we developed. I would rather ask him to go ahead and show this both.
Yeah, let me just formally finish the didactic presentation, okay? Okay.
Yeah, just
okay, hold on.
just allow me
Kumar, just hold on, okay? Okay, that ends the didactic portion of our presentation. And stick around. We have Rakumar from a company in India that's going to give a presentation And if you want to hang around, you can ask questions, pointed questions directly to him and to Ipe. Ipe is also going to participate. So, okay, Rakumar, thank you very much for coming, and it's all yours.
Yeah, thank you. So first, let me show the exoscope. So this is that exoscope. So this is a 3D visual system with zoom magnification and the working distance from 200 to 500 continuous variable. And we provide with the monitor 55-inch or the option as 32-inch. Hello?
Yes.
Yeah. So I think Dr. Magago and the other delegates is following this presentation. Can you view this page?
Yeah, we can see the image. Is that what you're saying?
Yeah. Dr. Magago, can you view this page? So this is the one we are supposed to bring last month to the hospital along with Dr. IP.
Yes, you can see.
Yeah. So this is the one which supposed to bring that. Unfortunately, we couldn't shift this to the hospital.
Okay.
This is that product, exoscope.
Okay.
So this was developed with guidance of Dr. Ipe, and it's just fine-tuned and it's been out for installations.
Yeah.
Okay.
This is kind of a last-minute thing, and so we really haven't prepared a long time. So we will be better prepared the next time, all of us.
Yeah.
So, do you have any questions or comments, so far?
So people were wondering, how is this different from a microscope? People were asking, what is this exoscope? Is it different from the microscope that we are using, the Pentero 900?
Yeah. Before that,
Far better.
I'll show.
I would say it's far better because the exoscope ergonomics is far better because you're not married to the optics. Here, you can move around the exoscope in whichever angle, and then you're sitting and looking at a screen. You're not moving around with it. Neither is your assistant moving around with it. So you're just using your foot pedal to move around, and then you can see everything. And with the 55-inch screen, the magnification is almost 70 to 100, and your hands are always in the field, and you're not in some funny position because the microscope is moving, and neither is your assistant in any funny position. So you both sitting down and watching a screen and operating. So obviously that's going to be the future. Plus, this is just a beginning because it's a digital image, and it can be married to many other digital images. Like, for example, we're trying to bring in with the next generation of Sanma Yoko, we're trying to bring in virtual reality, that is reconstructed scans into the exoscope field, so that we'll have something called the hypervision. So which means the scanned reconstructed image will be superimposed onto the exoscope image, and therefore you will have the ability to see what is behind your field and what is in front of your field, what is onto the sides of the field. All that you'll be able to see. So that is another big advantage for this.
So you'd not be looking on the eyepieces. You just be looking on the.
There's no eyepiece at all. There's no eyepiece.
Okay.
So you can see this one. There is no eyepiece.
Okay. So even the environment, working environment will be space for you to move around.
Yes. In a simple word, I can tell that this device, exoscope, puts everyone under microscope.
Okay.
Yeah, that visual, the assistant, the observers, everyone will be viewing the exact microscope view in the monitor.
Okay. Okay.
And
So
the depth and the field is far better compared with this regular surgical microscope.
Do you still have to drape the endoscopic holder?
That is different. This is exoscope.
I mean, yes, the exoscope holder. You have to drape so that you. How about this?
Sorry, I couldn't
Sure.
get your point. Can you please come again, sir?
How about the sterility in the surgical field? Do you have to drape the exoscope holder?
How do you move the holder with your hand, or how do you move it with a pedal?
Can you show the Sanpana, please? Ramkumar?
Yes, doctor. Yes, doctor. Just a moment, sir.
Okay.
That is another instrument. I mean, that's another scope. They will be showing the scope soon, very soon.
Just follow this video, sir. So this is that endoscope holder, robotic endoscope holder.
Okay.
This is a 3-axis rotation. And it is controlled by joystick or with the foot switch controls.
Oh, foot controls. Okay. I was going to ask that question.
So this is completely hassle-free endoscope procedures.
Okay. Dr. Magogo, have you ever used one of these?
Yeah, we have never seen this thing, but I think it's a very nice tool.
Okay.
Yeah.
Go ahead.
Can you use this for pituitary tumors, for example, instead of the endoscope? Can you use also for exoscope?
Dr. Aip, can you just guide on this, sir, this query? Dr. Aip?
Yeah. Yes. What query is this?
Yeah. Can you use the exoscope for transnasal, transsphenoidal approach? For
Yes, you can use the exoscope for that, just like you would use the microscope. In fact, the exoscope is far better. But I would suggest that you use the robotic endoscopic holder for the transnasal, because it's far better than any exoscope even. For minimally invasive approaches, this instrument, you can put in any endoscope and you can move the endoscope around. It will be millimeter precise. And we are developing something that will also wash. So like a pressure wash of the exoscope. It'll be like a pressure wash of the endoscope, so that you don't have to take out the endoscope all the time. So if that is also, once that is also perfected, then this would be the future of every endoscope holder, not only just in neurosurgery, probably in every brand, in spine, in cranial assisted, in transventricular, even in probably cardiology and other minimally invasive branches.
Okay, thank you.
Yeah. And
all right, guys, see you then. Okay. So show your the pictures that you were showing.
Yes, sir. This is the ocular
One with
surgical
very-
microscope. So
No,
this is
the
our,
one which you showed that screen to be in front of the.
yeah, just a moment,
Just
just a
this-
moment, doctor. You mean the images, doctor?
Yeah, the screen in front, the small screen in front of, yeah, that's the one. That's
This one, doctor? You
no,
mean
no,
this
not
one?
that one. The screen, the small screen in front of
Yeah,
your
I got it. This one. You're mentioning,
absolutely.
yeah.
Without that, yes, this is the screen here. This screen, once it is there, the surgeon can look at very high zoom things. I mean, you take off this eyepiece and then you can look at very high zoom and even operate from here.
Okay.
Thank you very much. I'll have to push off right now. So
Okay, doctor. Okay, thank you, doctor. Right.
Thank you very much.
Okay, I thank you very much. I guess we'll wrap it up now. Any closing comments, Juma?
So I think our next session will be the next 2 weeks. In the next 2 weeks. So today is the 4th. Our next session will be on the 11th, 27th. It will be 18th. So we welcome everyone on 18th for another Zoom case presentation from Tanzania. I think we'll have many. Maybe we'll have 2 cases from our side, and we'll send them in advance to Professor Aip and Dr. John, so that they can prepare more talks or more information. Thank you so much for the participants for attending, and we're looking forward to see you again.
Yeah. Thank you for putting this together.
Thank you.
Juma
Thank you.
And Ram, thanks for stopping by. And thanks to all the panelists. We'll see you in 2 weeks. Thank you.
Thank you all.
Okay, it's